Thank you. So, David Sung Young Kang from South Korea.
Good afternoon, ladies and gentlemen. My name is David Kang from South Korea. We're talking about a very interesting prosthesis in keratoconus, and I have to apologize. I have to go on a side track and talk about refractive surgery with cross-linking. These are my financial disclosures. I'm a consultant with Schwind and for EYREUM. The consensus in the literature is generally accepted that there are no posterior corneal changes to healthy myopic eyes after refractive surface ablation. Now, when it comes to cross-linked keratoconic eyes, there are contradicting reports showing minimal or no changes to posterior curvature or elevation to mild elevations found at 2 years post-op, which these elevations were thought to be due to disease progression. And when we're talking about prophylactic cross-linking with LASIK, the primary aim is to stabilize the cornea, so to prevent ectasia. There are numerous reports now citing the safety and efficacy of this combined procedure, showing the improved refractive and keratometric stability to a greater degree than the standard LASIK alone. And as is such, cross-linking, prophylactically combined with PLK, can be assumed to have similar beneficial refractive outcomes. This is a slide from a presentation our group gave at ESCRS earlier this year. We compared at 3 months PLK extra and PLK groups. The sample consisted about just over 100 eyes. The coefficient of determinations you see here are 0.95 versus 0.89. These are regression plots showing predictability. We're showing that for the PLK extra group, the scatter plots are bang on the dot, straight down the line, great predictability. Now, the aim of this study was to compare pre- and post-operative anterior and posterior elevations at identical sphere and toric ellipsoid fits with Scheinflug after conventional trans-PLK and trans-PLK extra. It was a retrospective comparative observational case series, recruiting about 40 eyes for each group. The cross-linking criteria were corneal thickness of less than 500 microns, or a calculated ablation depth of more than 120, or a predicted RSB of less than 300 microns. Anterior and posterior corneal elevations at the center and 2 millimeters, as well as the 4 and 6 millimeters, and also the point of maximal preoperative elevations were analyzed at 6 months. Now, because posterior elevations are arbitrary distances, distances from a fixed reference plane, we had to fix the reference plane between pre-op and every post-operative interval. Now, if you see here, the best fit toric ellipsoid, the dimensions of the toric ellipsoid are identical between the left, the pre, and the right, the post-operative Penicam posterior elevations. Trans-PLK was performed with the Mars laser and accelerated. The protocol was employed using Vivex Rapid with a pre-soak of 3 minutes, irradiation with 30 milliwatts for 3 minutes, pulsed mode for a total energy of 2.7 joules. There were no differences demographically for age, sex, refractive era, or keratometric values. The ablation zone or depth did not differ for each group. However, the PLK-only group did start out with more tissue. At 6 months, visual results were great for both groups, for 1.22 decimal and 1.27. MRSE was comparable. For anterior corneal elevations, as expected, there were central depressions for both groups, and also peripheral increases in anterior elevation. For the posterior corneal elevations in the periphery, we can see universally, in a universal direction, the posterior corneal elevation was seen to increase for both groups. However, the magnitude of this posterior corneal elevation was significantly larger for the PLK-only group. In other words, the prophylactic cross-linking was decreasing the magnitude of the increase in posterior elevation. For the central zone, also there was a universal direction for both groups to decrease in posterior corneal elevations, and this reached significance for the best fit toric ellipsoid calculation. For the point of preoperative maximal elevation, for all points, there was an increase in the point of preoperative maximum elevation, except for best fit toric ellipsoid, which showed a decrease significantly, and even survived deeper scrutiny. So trans-PRK alone induced a significant forward displacement of the peripheral posterior elevation. Centrally, there was a simultaneous backward displacement. We have seen this picture all those years ago, published by Dr. Cynthia Roberts, and even all those years back, I think this data set is showing and agreeing with that model. Prophylactic cross-linking reduced the magnitude of displacement of the posterior corneal surface and induced a backward displacement of the posterior corneal surface at points of preoperative maximal corneal elevations on a best fit toric ellipsoid calculation. So in conclusion, PLK alone, there was a significant forward displacement of the posterior peripheral corneal surface along with a backward displacement of the central cornea, regardless of the methods of calculation. And with prophylactic cross-linking and PLK, this reduced the magnitude of displacement of the posterior corneal surface and induced a backward displacement of the posterior corneal surface at preoperative maximum corneal elevations for best fit toric ellipsoid. Thank you very much.
Thank you, doctor. Questions from the audience for the PLK extra? No?
When looking at the difference in elevation, were these compared to the same best fit spheres or best fit torics?
Yes, sir. They were fixed for preoperative levels for every post-op interval.
Other questions? I have a question for you. Did you observe complication or AIDS development after the combined procedure?
No, sir.
Okay, thank you. Doctor